today to be allowed to introduce our speaker. Some of you may remember that Jason actually gave us grand rounds during COVID on gastroschisis. I mean, it was all virtual. So it's not his first time of speaking to this group about surgical problems, but we're now very proud and honored to recognize Jason as the new division chief for pediatric surgery. And we were just chatting. It was literally almost exactly a year ago today that I texted Jason and said, "Hey, do you have time to chat about a potential job opportunity here?" So it's funny how fast a year goes. And we find ourselves in the circumstances of today where he's here with his expertise on multiple levels and to begin his leadership role in pediatric surgery. You probably read a little bio. Jason did his medical school at Creighton University, the Creighton University up north, not the Creighton University here, obviously. And then from there, he went to Mayo Clinic, Arizona to do his general surgery residency. Several of us in the room trained in Mayo Clinic, Arizona. I met Jason after his second year of general surgery residency when he came to Kansas City to be our research fellow. That was 2008, I think. So it's been a while. And, you know, the first day I met him, I realized that there was something special about him. He's just one of those guys that's a doer and thinks clearly and logically and treats people with respect. And shortly thereafter, even as a second year, it became apparent how good of a surgeon he was. Subsequently went back to Mayo Clinic and finished his residency. And then came to Kansas City to do his pediatric surgery fellowship from 2012 to 2014. And despite best efforts, he decided to come back to Phoenix. So he spent about 15 months with the group here, many of whom are sitting in the audience today, as their partner. And shortly before I was hired as a surgeon chief, he decided to go back to Kansas City, which was a bit of a stab to the heart for me. But it is what it is. We find ourselves in different circumstances, and that was a pretty valuable decision for him, I think, because his academic productivity and his national reputation really grew exponentially after going back to Kansas City. He's published over 125 papers, similar number of presentations. His publications have ranged anywhere from gastroschisis, which he's talked about, to bariatric surgery, to trauma, to inguinal hernia, to TEF, pretty much the scope of what we do in pediatric surgery. He's also led several hospital initiatives and been the program director for their pediatric surgery fellowship in Kansas City. So although his career is, I think, kind of in the mid portion, his academic and leadership successes really speak for themselves. So he started the bariatric surgery program in Kansas City, and they're on the verge of becoming a center of excellence before we were able to recruit him here. So we're excited to have him here and hopefully continue that drive towards establishment of a bariatric surgery program with Dr. Egan here, and then moving on to center of excellence at some point here as well. So please join me in welcoming Jason. He's going to talk to us about bariatric surgery and the special needs patients.
Well, thank you, Dan, very much for those kind words. It's an honor and a pleasure to be back here at Phoenix Children's, a place that obviously I'm very, very excited to be back and be a part of, and be a part of the amazing group of surgeons and physicians and providers here. The opportunity to come back and talk today was a little bit of a self-serving thing as Dr. Egan is working to establish this bariatric surgery program. This is something that's been near and dear to my heart. When I started back in Kansas City, there wasn't a bariatric surgery program, but there's a clear need there. And it wasn't something that I actually was trained in or interested in or anything like that until I really started to kind of look at and kind of research and go through what actually the needs there were. Kansas City itself is a metro area of around 2.5 to 3 million people. So it's significantly smaller than Phoenix. And the need there was striking. And the need here is even more striking for their patient population. I'll go through a little bit of that here too, as we talk about and preface just this overall background of patient population. And so again, thanks for being here. As we go through, hopefully this will raise some interesting questions, discussion. Happy to take anything at the conclusion, either on Zoom or in person here. You can always chat with me afterwards on your cell phone or email or anything like that. No specific disclosures at all. A couple considerations as we start to talk about patients with obesity, and I wanted to be very clear about a couple of things. So first of all, this talk is about patients with special needs. That's obviously a very big catch-all statement, but it actually has a specific definition to what special healthcare needs mean. That's not something that I necessarily realized until I really started to get into this scope and practice. But really, special healthcare needs is defined as patients that have increased medical needs in this case above baseline. Again, that is somewhat subjective, but it is a big catch-all in that patients that need more services, need more time, need more efforts to go into their care. And so you can imagine what that necessarily means in terms of most of our patients, especially in the pediatric surgical world. But then especially how we then relate that to patients who need, in this case, bariatric surgery or weight management. Another thing when we talk about patients with obesity, and I'm being very specific in my language, and we need to be, is that we want to use person-first language, and that's something that was foreign to me, honestly, until I got into this space as well. And that's where we use people first, and we're used, instead of saying, you know, that diabetic patient or that cancer patient or whatever, that obese patient, it's that patient with obesity or that patient with diabetes. And what that does is it allows that person to be who they are, to speak for themselves, but to have that identity that is not their disease. But it also gives them the knowledge that they are not their disease, but they do have the disease. And it also then uses the ability for us to then call the disease what it is. As opposed to sometimes we try to use words that skirt around language, and especially it's difficult in the obesity space. And the more you do it, the more comfortable you are with it. But you actually have to then be very specific in the words that you use and the manner in which you speak to people. And I think that's something we all need to do for us going forward, is be intentional in the way that we talk and the way that we speak and the way that we act. So once we kind of get these considerations and definitions out of the way, I just want to talk a little bit about obesity in and of itself. You know, something that we don't necessarily deal with much as pediatric surgeons is in this space, but it's something we really need to consider because our patients are growing increasingly more overweight. Now, the definitions for these things, as we throw out obese and overweight, things like that, there's actually very specific definitions, and it's based on growth charts and things like that. We don't look at growth charts as surgeons, right? That's a pediatrician kind of thing, but actually, it's a really important thing in terms of our patient practice, especially in the space of obesity. Now, all of these things are based upon all of the definitions of underweight, overweight, healthy weight, things like that are based upon the growth curves and the CDC growth curves for national needs. Obesity itself is defined as greater than 95th percentile. Now, when we think of, a lot of us, we're all general surgeons, adult general surgeons, so we think of BMI. And BMI works great for adults, pretty great, right? But it's just ratios, right? Height to weight ratios. Kids, that doesn't work great, but it's a good approximation, things we can wrap our head around. But really the best thing are the percentiles. So you think of severe obesity, and severe obesity is defined as 120% of the 95th percentile. That's hard to say. It's a big old jumble of things. So it's really confusing for patients and families and for providers. And so really that equates to BMI of 35 or greater. Now, if we look at actually what severe obesity is, and these are the patients that those of us that do bariatric surgery are the ones that are taken care of. So there's class 2 and class 3 severe obesity. So class 2 is the ones that are essentially BMI of 35 or greater, or 120% of the 95th percentile. The important thing then is the next stage is the class 3 of severe obesity, and that's 140% in the 95th percentile. So when you're looking at a growth curve, right, that's above the 95th percentile. But again, how does that necessarily look on a growth curve, right? CDC actually has extended weight growth curves, okay, because of the patient population that we serve. And so as we work in this space, it's important to have that consideration as well too, because if you show a patient their growth curve when they're constantly just way above it, that is incredibly demoralizing. If you show them the growth curve on the extended weight and height growth curves, that actually they're still on there, but it's still well above, right? And so that's a different space for them to think about. And it actually shows them significant encouragement when they start to kind of come back there. So, like I said, this is, you talk about epidemics and pandemics, and that was something when I first started giving this kind of talk a couple years ago, no one necessarily knew what those words mean. Now we're all acutely aware. But obesity itself really is an epidemic into an American lifestyle. The percent of adults back in 2016, when we first started working in this space, was less than 40%, 30%. Now it's well over 40%. So this is most recent data from CDC, and this is self-reported weight by Americans. Okay, self-reported weight. So we don't necessarily know where that actually fits, right? We all report our weights a little bit differently sometimes. But if you look at this is all significant, right? You look at this is a map of America. The only spot with green is Washington, DC. You want to believe what they're actually self-reporting? But anyway, so Arizona itself, in the self-reported weight, people with obesity is 33%. This is adults, okay?
If you use the mouse, the people on Zoom can
Okay,
see the
perfect.
pointer, and you can get rid of that. Hit okay.
Yeah, it's perfect. Okay. So in Arizona, greater than a third of patients, adult patients, report having obesity. Now, the important thing about this is we know, and I'll talk about this in a little bit, is there's many social determinants of health that we look at in terms of the patients that have obesity. Now, we know race, national origin, socioeconomic origin, things like that play a significant role. One of the things that actually is considered, really significantly considered, is race in terms of obesity. And that's a lot of based on, genetics, but also based upon family origin and based upon national origin and national stature too. But when we look at patients with non-Hispanic Asian adults, a significantly lower BMI. Now, does that necessarily mean that they have obesity? Yes and no, right? The most and I'll talk about this a little bit, but the most recent guidelines from the ASMBS, American Society for Metabolic and Bariatric Surgery, in concert with the IFSO, International Federation for the Society of Obesity, actually lowered BMI thresholds for bariatric surgery. But they significantly lowered the thresholds for patients of Asian descent, okay? Because of the effects of obesity being so much greater at lower weights. So in Arizona, 13.5 patients that are Asian have obesity. Now, this continues to increase as we look at different patients of different ethnic backgrounds. Now, non-Hispanic whites in Arizona, almost 30%. Now we look at Hispanics, patients with Hispanic heritage. You can see just the difference as we look at the chart here. Lots of red, lots of orange. Almost 40% of adults in Arizona. Non-Hispanic, American Indian, or Native Alaskans. Significant increase in percentage of obesity. 47%, almost 50% of patients with American Indian heritage in Arizona have obesity. Non-Hispanic Black adults, 40% in Arizona. This is the same trend follows with children. So that means like half of your patients, right, are going to have some level of obesity. So it's not something that we can ignore. It's not something that we can just leave be. It's not something we can just say, okay, these children, that's just random person, things like that. It's everybody. And we're all going to face, as these patients continue to get older, we're all going to face the things that come along with the obesity, okay? Not only, yes, there's for laparoscopic procedures, maybe more difficult access. Okay, there's other things that come along with that too in terms of surgical planning, right? But it's also extremely important to understand that these patients have higher risks of all of the comorbidities that come with it. Diabetes, high blood pressure, sleep apnea, cirrhosis, all of the things that come along with that are really important. So again, just like I said in adolescent or in adults, the adolescent population is mirrored completely with that. One of the things that we then consider in patients with obesity is that we can look at their disability status, okay? We know that patients with obesity, patients with disabilities, they have significantly higher rates of disability, their obesity. In adults, 36% of patients with any kind of disability or self-labeled disability have obesity. And that's mirrored again in children, about 1.5 times the baseline patient population. So what causes obesity? Right, the common parlance, right, is that it's just calories in versus calories out, right? That's obviously not the case, okay? It's very multifactorial. The more and more we get into this, right, we understand that it's actually a significant amount of genetic predisposition that allows this to be. And you see that, of course, in the graphs that I showed earlier in terms of the cultural and the racial and ethnic disparities that we see. But we also see that there's significant environmental factors in terms of zip codes that you live, access to food where you're from, access to food, different kinds of food, access to parks, all those kind of things play significant backgrounds in terms of the rates of obesity we see in patients. Now, like I said, genetics plays a significant role, right? it's less common that we find genetic associations with obesity, but there are several markers, genetic markers that we actually run a lot of patients for. And we see there's lots of different kinds of genetic forms of obesity. We also see that because of this, there's several groupings, the leptin deficiencies, the POC deficiencies, those are kind of the most common ones. But several of these, there's actually now targeted drugs that are being developed or are just recently on the market for. The ones that we hear about that we know most commonly about is those that practice in the pediatric world, Prader-Willi, Alström's, Albright's, Beckwith Wiedemann, that's one that we hear about, especially as pediatric surgeons, the tumors that are associated with it. So there's lots of different kinds of genetic syndromes, genetic predispositions that give you risk or higher risk, higher associations of obesity. And that's where I think a lot of our work is able to be done as the surgeons and medical providers in terms of identifying these patients early on, referring them early on, and then also then counseling the patients and the families about these increased risks. But also, these things make more difficult to treat, right? Because there's a multifactorial nature in these obesity syndromes. And so that's where this kind of comes in. And I want to kind of push us a little bit in terms of our thought and our treatment of these patients, right? Because as we work to develop systems here at Phoenix Children's, we don't want to necessarily exclude patients that are the tough causes and patients that are the tough cases and patients that have these syndromic causes, because these are the ones that can really benefit. Yes, there's going to be work. Yes, there's going to be more multidisciplinary work in terms of patient care, but at the same time, these patients can really benefit from the work that we all do. One of the things I didn't necessarily mention, because it wasn't necessarily a genetic cause necessarily, was hypothalamic obesity. Now, we all know that the hypothalamus is an extremely complex portion of our brain that controls a significant portion of the hormonal control of our body, especially in terms of our endocrine functions, right? But we all know too that in patients with like craniopharyngiomas or vascular malformations, they can have injury to their hypothalamus or disruption of their hypothalamic pituitary axis. And that causes dysregulation and disruption of these many different hormonal controls. One of the big things that comes of it, though, is they can get significant obesity. And it's a really, really hard thing to treat. We've done operations on these kids with varying success, and I'll talk a little bit about that as we go later, but it's one of the things that we need to really remember and we talk about such patients is not only do they have significant obesity, but they have significant other endocrine and metabolic derangements that come along with it as well, too. Now, yes, I'm a surgeon, but I think one of the most important things to understand about bariatric surgery and this patient population, right, is that bariatric surgery is a tool. It's a tool that works really, really well in select patients and patients who are ready and families that are ready for it. It's a tool that works extremely well in preventing, in repairing, and in some places, in some disease processes, even curing the disease, such as diabetes. Right? We have patients that come in with significant amounts of insulin. They're able to essentially get off their insulin post-op day one. They have 200-300 units of insulin a day. They come in the hospital, they're off their insulin. Okay, we still watch their blood sugars, right? But what other operation? What other thing that you can do that has that significant immediate impact on patients for now and for the rest of their life, right? But having said that, it's not for everybody, right? Most importantly, it's for patients that need it and want it. But it's part of this entire system. It is part of a system that has to be done together in order to make it work. And it's part of the medical part of it, right? Is that not just surgery, but there's the medical part, the medical providers, the medical people that we all have to work together through. And that includes patients, they need their intensive lifestyle modification, which is diet, exercise, things like that, right? There's different medications that we can use, and I'll briefly talk about that. Obviously, that's well outside this scope. But they also need a significant behavioral health component to this, whether it's therapy, social work, but they also need really truly to understand themselves and the process that they're in, to understand what they need to do, how they're doing it, and also how they need to conduct themselves and understand themselves to be successful going forward. And of course, they all need exercise, right? But it can't just be exercise. You all watch Biggest Loser, right? Where they exercise 6 hours a day and they sit there and they lose 100 pounds or 150 pounds, but then they go home and after 3 months, they gain it all back. Well, why is that? Is that because they, quote unquote, fell off the wagon? Not necessarily. It's right because our metabolic set point is different. And our metabolic set point is different because what your body does in response to especially, in those cases like starvation mode, your body changes the metabolic set point. You give you metabolic carts and things like that to patients, and you find that everything is lowered, right? The baseline metabolic rate, is significantly lowered. And so you need to do something to disrupt that baseline metabolic rate, the genetic programming and things like that in these patients to help them be successful. You know, part of that is the lifestyle treatments, part of that is the therapies. All of this works together in concert for that. One of the things that does this fairly well in some patients is the pharmacotherapies. All that's listed up here are ones that are FDA approved in children. There's obviously significantly other medications that are out there, and we won't talk about them to some degree. But the most common ones you hear about is like metformin. Obviously, that's for type 2 diabetes. Orlistat, that's the one that gives you difficult bowel movements, and because what it causes is inabsorption of your fat. It works a little bit, but not long term because it has such negative side effects. Phentermine is a stimulant, appetite suppressant. It's short dosing, or it's a short course label for a patient 16 years of age or older. Liraglutide. Now, so the GLPs, the ones that everybody hears about, there's shortages, there's usage, usage outside of normal scope, things like that, right? So that's the liraglutide is the one of the first ones that was developed. That's right now the only one that's approved in children 12 years of age and older, with and without diabetes. So that's an important caveat. So it's approved with and without, right? You hear about in adults, right? There's Zepbound, Mounjaro, right? That's probably the biggest one now. So they're recently with the best the weight outcomes in adults. So Mounjaro and Zepbound are actually the same drug. That's like Wegovy and Rybelsus is the oral form of semaglutide. So semaglutide actually has 3 forms: oral, and there's diabetic. There's a diabetic form and a non-diabetic form. So all of these new drugs are being FDA approved in adults, both as a diabetic form because the GLPs actually have a significant anti-diabetic effect, but then also they're being approved as a weight loss drug. So they can have a dual approval through different trade names. So there's a little bit of trickiness in terms of when you think about that. One of the newer ones out there is setmelanotide. And that's actually a specific melanocortin receptor agonist. And that one's approved for patients with the genetic cause of obesity. So that's really exciting. It's really super expensive. And again, it's very specific. But in terms of the future, this is kind of where the future is hopefully to go, right? We are able to run genetic testing on patients, find if there's significant associations that they have, and then actually treat them with the pharmacotherapy that would work specifically directed at them. So again, some of those medications work, some of them work for specific patients. Again, you have to take them for the rest of your life, right? So there's some wear off effect for them. And so you see patients that have, effect with medicine, but the effect sometimes wears off. And it wears off over time because the way the body works, the way our human brain works, all of those kind of things go into long-term effects. But what we see through multiple studies, when you compare surgical versus non-surgical outcomes in patients with obesity, is you see this trend. Okay, you see patients that have surgery, they lose weight. And yes, they gain back a little bit at 2 to 3 years, sometimes even 5 years, but it's not to the same degree. And you see this long-term outcome in adults, in children, and adolescents with the long-term success of bariatric surgery in these patients. There's different options that we can do. There's a restriction of options where we take the stomach and make it smaller. There's malabsorptive options where we actually change the way the intestines are routed to make it different, so that they actually don't absorb the fluid and the food as well. And there's combinations thereof. The most common one that you hear about is gastric bypass, and that was the historical one that was done for a long time. That's the one I did in training, and most of us did in training, where you make a small little pouch in your stomach. You make a small little pouch in your stomach, and then you reroute the intestine, and you hook that up, and you hook it up again, okay? It works really well, but it's restrictive and malabsorptive. But the malabsorptive component and the technical complexity component of this operation make it so that we don't really do it anymore, especially in children. The reason for that, it can have significant long-term and short-term complications because of all the rerouting, all the stapling and things that we do. But then also too, because it has the malabsorptive thing. Think about trying to get a teenager to take any kind of medicine right now. It's really difficult, but think about trying to get them to take bariatric vitamin, iron, calcium, vitamin D, sometimes vitamin D shots, and a bunch of other things. That's what you have to do with gastric bypass. Because of the malabsorptive component to it, you have to take significantly more vitamin and minerals with it. But you also have a significant, because of that, even if you miss doses, and even if you do the right things, you can have even a higher chance of having issues with vitamin and mineral deficiencies. So that's why the option came about for the gastric band, and this seemed really like a great idea for adolescents back when we first started doing bariatric surgery in the early 2000s. However, never got FDA approved because of the problems that have that it has with it. Never got FDA approved in adolescents. Let me put that back. Because it causes significant problems with reflux, the band flips, it rotates, turns, all that kind of stuff. We don't do it. We really don't. There are some adult centers that still do it for adults, but not in kids because of the problems that happen with it. So now what do we do? So we almost every single adolescent center in the country, and I'll show you some data on that in a bit, does sleeve gastrectomy up front. Reason? Well, it works. It works really good. Really low complication risk. We're talking about the same complication profiles getting your gallbladder out. Okay, like 1% long-term complication rate. It's not reversible, so you take out that piece of the stomach. Okay, this piece of stomach right here, and that's gone. So whereas gastric bypass right here, you're just kind of rerouting things. It's not really reversible either, but you're still leaving things in place. Here, you're actually taking out about 2/3 to 3/4 of your stomach. Okay, really low risk in terms of vitamin and mineral deficiencies, and that's really appealing for a patient who's 14, 15, 16. It's the rest of their life to live, right? In terms of ability to maintain their vitamin and minerals, because you're not going to lose hair, you're not going to have anemia, things like that. Also, too, it leaves the opportunity for other operations. Okay, you don't burn any bridges, so to speak. You can convert this to a bypass. You can convert this to a duodenal switch. So it is very versatile in terms of, especially your first upfront operation that you can do in adolescent. So there are future things that are not yet approved in kids. The endoscopic sleeve gastroplasty, where you would use a EGD scope and go suture the stomach together from the inside. There's balloons, things like that. None of these are approved in kids. There is some work in this space because the appeal, obviously, in adolescents and kids is to be as less interventional as possible. But none of these are quite FDA approved yet. Give us maybe in the next 5 to 10 years. So which one actually works better? If we look at the two most common operations that are done, sleeve versus bypass, they actually work about the same, honestly. This is a prospective randomized trial, which is pretty hard to do nowadays in terms of surgery. They looked at complications, they looked at outcomes, and there was no difference in terms of outcomes in gastric bypass versus sleeve gastrectomy. And they found very similar in terms of weight loss, but they found that there was significantly less serious safety events and adverse events in terms with patients with sleeve gastrectomy. And again, that's exactly what we've been speaking for and one of the appeals for in terms of adolescents and children. This is what we see when we looked at what most centers do in terms of operations for children and adolescents. We see the vast majority of centers are doing primarily only sleeve gastrectomy, but about 80% of the population gets a sleeve gastrectomy. And that was 2018. It's probably about 90%. And again, when we look at this in kids, again, it shows the same. In most cases, our sleeves in most cases do really, really well. Weight loss, one of the things that when you talk about when you work in the space of bariatric surgery, you talk about excess weight loss. That's really hard for patients and families to wrap their head around. So ultimately, I tell people you lose about 1/3 of your weight. Okay, you have some patients that lose a lot less and lose a lot more. Okay, but when you think about what that looks like for an adolescent, say you have 300 pounds, you start at 300 pounds, 1/3 of that's 100 pounds. So if you go from 300 to 200 pounds, that's a significant amount of weight loss. Okay, and that happens usually within the first 6 months to a year. What other thing are you going to do to be able to get that for you with this kind of outcomes? Not much. Okay, so this works. It works really well. Patients, families are like, oh, I don't know about that. My response always is, you had cancer that was going to kill you in the next 30 to 40 years. Would you do something about it? Of course, everyone says yes. Well, this is a slow growing cancer that will affect you negatively in the next 30 to 40 years. You better do something about it. And they do, right? Because it works. It works and it's sustainable. And it sustains for the long term. So if you look at 5, 10, 15 years, all of the longitudinal studies that have been done that show long-term weight loss in children, it's sustained. Okay. It's different for every patient, right? There's some patients that lose lots of weight and gain it back. There's some patients that lose it and keep it off. But overall, when you look longitudinally at a patient population level, most patients lose, like I said, around 1/3 of their weight, okay, and then keep it off. And keeping it off means, and look at the sleeves. So yeah, you see that inflection point in a couple of years, but that's still 20 to 25% weight loss over long term. Again, it's safe. If you look at the long term outcomes with this, it's very safe in terms of complications, but also really safe in terms of their comorbidity resolution. And it's safe across both sleeve and bypass. Long-term comorbidity, long-term effects of this, risk of bleeding and things like that, overall extremely low, less than 1 to 10%. And when you look at the other comorbidities that come along with this, like hypertension, diabetes, and things like that, those things go away at clips that are anywhere from 50 to 75% chance with these operations. And I highlight this because this is becoming even more evident as we talk about these medications. When everyone thinks about the hunger hormone ghrelin, and one of the interesting things that we did that we're working on publishing is we check a ghrelin level in the operating room and then a ghrelin level post-op day 1, and you find that their ghrelin level is cut in half from day 0 to day 1. So which is pretty significant, right? That's the hunger hormone. To the fact that we see patients that they forget to eat, they forget to drink. And you have to like set reminders on their phone to tell them to drink, because the stimulus that they have is changed to such a degree that it's just not there. And that's something that's hard for people to comprehend. But then when patients have that, they're like, it just shuts it off. Granted, it comes back over time, but that right there is really what and it's it's multifactorial. Probably it's not all just ghrelin, right? Because people have tried anti-ghrelin medicines and those don't necessarily work, at least in the ways that we know. But there's signals that we get that change immediately after this operation. And that's really important when we look at our syndromic causes of obesity. When we look at our hypothalamic causes, when we look at Prader-Willi, where people have this overwhelming, uncontrollable desire. And it's not even a desire, it's just a push, right, to eat and to drink. But that's where this changes, okay? And that's where it's important, because this changes because you think, okay, if I have a patient with Prader-Willi and they're gonna go, this is honest truth. They're breaking fridges, they're breaking locks, they're raiding traps, things like that. That is what happens. That desire is part of this. And when this changes, their outcome changes. And that's really what the profound effect we see is the neurohormonal changes that come along with bariatric surgery. It's not just the restrictive part of it, right? Because if you think about it, just making the stomach smaller, none of this would change. It is the fact that the stomach itself is a significant hormonal agent in all of this. So clearly there's a lot we don't understand, and there's a lot of work that's going on here, but we need to really consider that as we go forward. One of the things we think about adolescents in terms of going forward is, what about their growth? We know that adolescent growth, that one of the things that we saw when we first started doing this is that a lot of insurance companies were like, well, you need to be adult height. You need to be over 18, you need to be adult height to be able to qualify this operation, or you need to have mature bone growth. That's actually backwards, okay, because these patients actually have stunted growth, stunted bone development. And what we find is that when patients have their operation, they actually then get back on the growth curve after the operation where they were supposed to be, because all of their body's expenditures were not being used to maintain their weight. It then can go back into growth. And that's something that's really important to kind of understand. We've done a lot of education with insurance companies and payers to understand that too. And that's actually been removed from a lot of insurance requirements. So what about patient now, getting back to actually what the topic of this presentation is actually about, and it's what about patients with special needs. And so this is from a little bit, probably about 5-6 years ago, looking at patients with cognitive impairment, and actually showed that patients compared to quote unquote patients without or their controls, that they actually did just as well, if not better, with their long-term outcomes in terms of BMI resolution, in terms of comorbidity resolution, and in terms of outcomes. Now, why is that? Probably multifactorial, because we find that patients that are followed by the special needs providers, they probably see them more often, and so they probably keep more touch points on them. So they follow them more closely. Is it because parents are more in tune? Is it because patients are more in tune? Maybe all of those things. Or is it because that the genetic or predispositions that come with this actually improve more with the operation? Hard to say. But it really has been shown through several small studies that these patients do just as well, or if not better, overall. Caveat to that is the hypothalamic obesity. Like I said, it's extremely difficult to treat in terms of medical treatments, but it's just as difficult to treat in terms of surgical treatments. Now you look at some of these patients, and it's granted, this is a handful of patients, and it was 20, looked at the outcomes after bariatric surgery. And this is a review too, really show that, a lot of patients lose, habit needs a change. A lot of patients lose significant weight in the first several months after bariatric surgery, up to a couple of years. A lot of them level out, okay, which is still good because they're losing weight. But the other significant portion of them kind of gain it all back. It looks like when you kind of stratify this in terms of the operations that they get, it seems like patients do a little bit better with bypass than they do with sleep. This seems to be one of the operations, one of the conditions where you really consider doing a bypass in an adolescent first over a sleep. Again, still the data on this is still maturing. It's still very few, hard to make long-term conclusions on this. But it's something in these patients that really you want to consider at least referring for, because again, the other thought to this too is that you lose very little by doing a sleep up front, right? If it works, fantastic, then you're done. If it doesn't, then you can convert it to a bypass, convert it to a switch, things like that too. So something to kind of talk about as we go. About creative release syndrome. Again, difficult condition to treat in terms of the patients, in terms of providers, in terms of parents. It's a very multifactorial disease. But what we see is that patients actually do very well. They do well because of the multidisciplinary team that has to be involved with these patients both before and after the operation, and also for the parental commitment and the patient commitment if possible. So, when we first started looking at and talking about Prader-Willi and bariatric surgery, we found that a lot of people were very hesitant and still are, but more and more studies are coming out that show that bariatric surgery actually has a reasonable effect in patients with Prader-Willi. But it's not something you want to dive into. It's something they really need to be very mature about and have significant discussions with patients and their families. But it's something that we shouldn't just shy away from because of the effects that it has. Like anything else, some patients are going to do great, some patients are going to do less great. But it's, as long as we all have expectations that we work through together, patients are actually do okay. And again, that's again echoed in these graphs here too. What about transplant patients? Now, in patients that have had transplants, people can actually have use bariatric surgery as a bridge to transplant availability because of their eligibility. Because there's obviously in transplant surgery and in transplant medicine, there's significant BMI cutoffs, right? In patients who don't meet those cutoffs, well, they're not going to get an operation. So what do? Try medical treatment, things like that. When that doesn't work, then you can actually do bariatric surgery. Patients with renal failure, on dialysis, you do that. Patients who've had kidney transplant, we do bariatric surgery on that, okay? On most patients, and it works well, okay? What about patients that have liver failure or impending heart failure? You can do bariatric surgery on those patients too, as long as you have a multimodal disciplinary approach, right? I've done all of these. Okay? This is something that's not new. This is something that actually we've been able to do and do successfully, okay? So it's something that really you don't want to just shy away from. And it's something that is in the armamentarium of surgeons to actually be able to help these patients in terms of long and short-term outcomes, okay? So we need to really start thinking about, as we care for these patients, is that obesity isn't a contraindication, okay? It's an opportunity. And it's an opportunity for these patients and their families to actually become and be more healthy in terms of their long and short-term outcomes, in addition to comorbidities and the special circumstances that they have. And that actually includes younger patients, okay? When we first started doing bariatric surgery, people were looking at, okay, 16, 17 is the minimum cutoff. Some of the youngest ones reported in literature are 4 and 5 years old, okay? And that's, essentially in patients that, are impending death from respiratory compromise. The youngest that we've done is 10, okay? And that's, you seem really young, right? But there's reasons for that, okay? There's reasons for doing that in patients that would be not long-term survivable because of the conditions that they have. Again, progressive, yes, but reasonable, because there's nothing else you're going to be able to do. And they do well, okay? If you look at patients that are less than 13, you compare them to 8 controls, they do just as good, okay, if not better, okay? Maybe because their genetics, maybe because their metabolism, hard to say, but they do very well. So the age is not a contraindication to bariatric surgery, okay? So it's something you just want to really keep in your mind too, is that there's never too young to refer. It's never too young to refer a patient that has obesity, because you want to get to that patient as early as possible. I'm not saying every single patient, every single young patient needs the operation, but every single young patient needs the discussion. These are difficult discussions to have, especially for pediatricians and primary care providers who have limited time. Okay, but that's where those of us that work in this really are able to have those conversations in a time and a place and space where that's able and people feel a little bit safer. Now, one of the important things that just came about, especially for the pediatricians, is that the AAP just released clinical practice guidelines. This is the first time that they worked through all the available literature and a group of pediatricians. Sarah Hampel actually was a pediatrician and a weight management physician in Kansas City that I worked with, and she was the lead author on this clinical practice guideline. So the AAP put this out, and they talked about all of the different changes and all the different things that are available for patients with obesity and how we treat them, how we work them up, laboratory workup, and everything. It's all in this guideline, which is fantastic. But in here, which is great, they actually address bariatric surgery and talk about how patients should be referred early for bariatric surgery. And so that's something that's really important to see and understand, and especially in the pediatric realm, because of the AAP, putting this guideline out actually is important because they recognize the importance of obesity, but also the importance of treatment of obesity, identification of obesity, and then, self-certainly of the role of bariatric surgery in this patient population. And again, I talked about this a little bit too, but the current adult recommendations, they lowered the BMI thresholds. So for a long time, since 1991, when the initial NIH criteria came out, the traditional cutoffs were BMI 35 with a comorbidity, okay, or 40 without a comorbidity. They lowered that, so it was 30 with a comorbidity, and then now 35 with a comorbidity. That's 5 BMI points down, which corresponds to anywhere from about 10, 20 pounds, probably depending on patient size, not 25 pounds less than it was before. So a significant decrease. But then they also expanded the recommendations for patients, essentially took away almost all of the contraindications for bariatric surgery. Okay? They said, there's no upper BMI limit. There's no other comorbidities that you shouldn't do bariatric surgery in, such like cirrhosis. Because us as general surgeons, where essentially always said don't operate on patients with cirrhosis or things like that. That took that all out of the window. So really, there's very few contraindications to bariatric surgery. I mean, they even talk about patients on LVADs. So essentially, they show over and over and over again the short and the long-term effects and the short and the long-term safety of these operations. And you're like, okay, well, that's great. That's adults. Okay, we're actually in the process right now. I'm on the ASMBS pediatric committee. We're in the process of rewriting these guidelines for kids, for adolescents. The last time that was put out was 2018, but we're right now working on rewriting those as well. And it'll be essentially reflective of the adult literature. Of course, that'll take some time to get those out, get them circulated, and of course, working with the insurance payers as well, not to change their baseline care listings and their approval process. But that's something that we need to do too. Okay, once these guidelines are up, we need to bring them back to those that make those decisions and work these through. And the next steps here too, right? At Phoenix Children's, Dr. Egan is developing a bariatric surgery program here at Phoenix Children's. And that'll be in concert with our endocrinology colleague and our GI colleagues and our many other colleagues here at Phoenix Children's. So I'm excited to see where Dr. Egan takes the program here, and just being able to see that and support Dr. Egan. And we've had lots of conversations about all the mistakes that I've made in working through this program and the process and all the things and all of the hard bumps that I had going through this, and hopefully Dr. Egan's going to have to understand what he does here in the future to help serve the patients and families of Phoenix Children. So look forward to working with y'all as we work through this and all our other processes here. And it's been, like I said, a pleasure and honor for me to be back here and be a part of this group and this team. So happy to take any questions as we go here now and in the future as well. So thank you all very much. Here's a couple QR codes. One is just for the general surgery team here at Phoenix Children's, and the other one is the clinical practice guidelines for obesity for children. So thank you all very much.
Not yet.
Yes, that's great. I'm sure we'll have a few questions. Eric's got his hand up back there, so start with you.
Yeah, I think Jason, that was a great update for all of us. Great, a lot of information. Has there been data showing, well, first of all, can you share what your patients post-operative stays? And then number two, is there data showing decreased healthcare utilization in some metric for these kids that we're talking about, that are children with obesity and adult disability, we're talking impairment, post restricted.
Thanks, Dr. Hanson. The question for you on those on Zoom, the first question was, your first question was what? Okay, yeah, our length of stay. So the length of stay that we usually had was anywhere from 2 to 3 days. We were a little bit more conservative with that. Honestly, most patients are ready to go at day one. A lot of adult centers will send their patients home immediately from the PACU and see them post-op day one. In children, we're a little bit more conservative in terms of we want to make sure that they're tolerating their liquids okay and their pain is completely gone. But by the time it's 2 to 3 days, they're all off all of their narcotics, and most of the time they don't need much in the way of narcotics at all postoperatively. And so they just go home with Tylenol, ibuprofen. And I didn't talk about post-op protocols or anything like that. Obviously there's significant enhanced recovery after surgery protocols, pre-op, post-op, intra-op, everything with that. But on average, the stay is about 2 to 3 days. Our special needs patients tend to stay a little bit longer. If you have a patient that, doing a liver transplant, honestly, that's a lot longer. But anyway, on average, about 2 to 3 days. And then your second question was in terms of outcomes, in terms of healthcare resource utilization. There has not been a lot published in terms of healthcare resource utilization in terms of patients with special needs. I think that's an excellent question, a good space to work on. But when you look at in terms of adults and adolescents, just in general, that has been shown significantly to decrease their number of healthcare visits over the course of the next 10 to 20 years, but then also their overall healthcare cost utilization as well too. There are some payers, Arkansas Blue Cross and Arkansas Medicaid, which is one of them, that was actually fairly staunchly against bariatric surgery, that recently kind of changed because of that. Now, when they did their actuarial analysis, they found that bariatric surgery actually decreased costs, decreased healthcare visits, decreased their costs, right? And that's how you have to get this to change, is you have to show the insurance companies, especially in kids, okay? And here's where my soapbox and bias starts to come in, is that insurance companies don't want to pay for this in kids because in 3, 5, 10 years, they're off their dollar, right? They're going to move from Aetna to Cigna to Medicaid to whatever, and it's off of that particular plate. So they have no impetus to pay for these patients because they're going to be off that parent's plan. Okay, the plans that were the easiest to change were the Medicaid plans. Okay, the plans that have been the hardest are the private payer plans. But what we're being able to do is show them their costs in the short term are significantly better, and their outcomes in the short term are significantly better to decrease those resource utilizations to that point. And that has flipped some of that availability from insurance payers. But from the special needs population itself, we haven't really studied that, but that's a very fantastic thing we should do for sure.
Thank you so much. We've been talking a little bit about the program here, and I wanted to kind of hear your experience. One of the thoughts we had was, how do you select the right kid that's ready for this? And, when we were having these conversations, Craig and Endo and us, we thought about it like, is there almost like a selection committee, like a liver transplant selection committee, or someone that looks at it? How have you guys done that, and how have you approached kind of selecting the kids that go to surgery?
Yeah, that's a great question, and there's a lot of different ways to do that, especially in the pediatric world. Ultimately, the way that we had done things was definitely multidisciplinary. So first and foremost, when you first start, you want to find the perfect candidates, right? The ones that are going to be the best and have the best weight loss and things like that. There's no such thing. There's no such thing as, it's like, liver transplant kind of thing. There's no such thing as a perfect candidate for anything. You find patients that want the operation, you find patients that understand the operation, and you find patients that are going to be able to show up to their appointments. And essentially, if you're able to do that and you meet the criteria, you give them an operation, okay? Because no one is going to be able to do everything. No one is going to be able to lose 50 pounds before the operation. Otherwise, they wouldn't need the operation. And then also, too, no one is going to be able to do everything perfectly. And so what you want to do, yes, is risk stratify. But you also don't want to limit, because patients wouldn't be in the space that they're at if they didn't need help. And that took me a little bit to understand, is that our patient population, they need help. And to limit their ability and their access when we have a tool that is really successful can actually cause significant problems with them. If they come in thinking I'm going to be able to get this operation and then we turn them away, when we actually have availability and opportunity in systems, then that actually causes significant deleterious effects on them from a psychological standpoint too, and then they can actually go in a more negative space. So when we work through this, yes, we had specific criteria in terms of, essentially, we looked at in terms of, we gave everybody a sleep study because we found that was actually the easiest comorbidity to diagnose in patients that insurance carriers liked. So about 95% of the patients have sleep apnea. So we put everybody through a sleep study, then they had a comorbidity, then that would get them insurance. So that was one of the criteria that they had to do. They have to be relatively consistent in terms of their showing up to their preoperative appointments. They have to understand their requirements in terms of pre and post-op. They have to, be physically fit in terms of their ability to tolerate an operation, which an adolescent essentially every single one of them is. We didn't get echocardiograms because even in our heaviest patients, 500-600 pounds, that was normal. We got the things that insurance required. We found that those patients all did well. People ask, okay, do they have to lose weight preoperatively? No, because again, otherwise they wouldn't be in the space. We find especially some of the sicker patients, the significant diabetic patients, right, that are on huge amounts of insulin, no matter what you do, they can't lose weight. And so we found that restricting patients to preoperative weight loss actually was limiting in a negative way their ability to get an operation. So we really just wanted kind of weight stability, best that we could, and that actually was fine. We just didn't want them, gaining weight significantly before an operation. But then in terms of selection, we worked together to make sure patients were ready and the insurance approval, things like that. And then ultimately came down just, once we worked that through, and then ultimately just the, surgeon discretion in terms of final approval and things like that, because obviously we'd be the ones doing the operation. But, that was worked through together as a team. And then once the surgeon said for sure, yes, then we great question. Thank you.
Yeah, so mine is more general and probably more strategic than for us, but I've run into this too. When you have a patient who has obesity and it's very obvious that it's affecting their lives, and like for us, like they have fatty liver, they do a gallbladder or something, like, you know what, you guys can think about like figuring out a plan. Some parents are receptive to this, some parents are really just not at all. So what do you think the best way, or there have been studies that show kind of the best approach to talking with folks? I mean, you kind of blunt to surgeons and the pediatricians a little nicer about this. Like, what's the best language to use? What's the best kind of verbiage, I guess?
Very good question. I forgot to do this for Dr. Patel's question, but for Dr. McMahon's question was, how do you best speak to patients and their families when you see them for other issues, when you find that they have significant obesity that is causing problems in their lives? It's a difficult problem, right? And like anything else, the more that you do it, the more you're comfortable with it, and the more that you express outward comfortability with the problems, the more that patients are going to, families are going to be receptive. And so one of the ways that I treat this, to a point, we see, pediatric surgeons, we see patients that, ingrown toenails and pilonidal disease and cholecystitis and gallbladder problems and things like that have obesity and much other problems. So one of the ways that I kind of work this through is I say one of the things that we do as surgeons or pediatricians or as healthcare providers, this is, when you come in, we take your vitals, we get your height, your weight, your blood pressure. We also look at the things that are contributing to the current problem that you have. And one of the things that we find with you or however you want to address that, is that you're significantly overweight. And I know that might be kind of hard to hear, and that might be something that no one has ever told you before. But what we see is that because of the weight that you have, this problem that you have is significantly worse. And what we want to do is not only just help you understand that, but then also give you some resources and options to help you treat that. And I know it might not be something you want to hear today or talk about today, but just know that we have resources available for you in terms of literature or institutional resources or whatever your situation might be, to be able to help you with that. And if it's not something you want to talk about today, I completely understand that. But I would do the same thing for a patient who came in if they were smoking, or if they had heart disease, or anything like that. This is exactly the same. And I know that there's a negative connotation in terms of our society for weight, but it's something that we all need to normalize and talk about and really work through together. So just understand that I'm working through this with you, and I'm here to help you and support you along this journey. But your weight is significantly contributing to your problem X. And that's kind of how I approach it in that way. And it's a little bit of a kind of background way to get there, but it kind of works the patient through the steps that you've got to kind of work through to get there. And then, once you have the solutions in there, if they're interested in X, Y, or Z, then I throw out, hey, I'm a bariatric surgeon. Sometimes they're like, whoa, but sometimes they're like, oh, great, we've been, trying, so you have to kind of work through that. And I'll tell you the truth. When I first started doing this, and I first started, talking to patients about this, and it still happens even after I've done this for, 7 or 8 years, I get patient complaints about it. And you know what? If that's the, quote unquote price of doing business with this, that's what you have to do. It's the right thing for the patient and their family. And you have to be upfront about it, honest about it, and use the language that you can to help them work through this.
So, yeah. My question, if you talk a little bit more about the obstructive sleep apnea, because we do see as pediatricians, kids, they're developmentally mature. They need a CPAP mask, they won't wear it. And it's really a nightmare problem to try to fix. And I mean, the worst case, I remember a kid that was on 6 West for 4 or 5 months. Because we couldn't get a placement from who's gonna take a Prader-Willi kid who's, I think he was over 300 pounds. He couldn't walk anymore because he was so obese. He needed, sleep CPAP, and it was just a nightmare to get in place, even though he's medically stable.
Yeah.
And I think in retrospect, I mean, maybe we could have got that kid a surgery and got him out the hospital a couple months earlier.
Yeah, I mean, those are the kind of patients that really would benefit from an operation, but yeah, the sleep apnea was something that prior to doing this, I didn't necessarily realize the difficulties in it, as well as the significant number of patients that actually had undiagnosed sleep apnea. And when you start talking about it and start talking to parents and families, like, it's a big deal. And it actually contributes significantly to their life and their quality of life. In terms of how they're going to, you ask them, are you sleepy? Well, yeah, I'm actually sleepy all day. I do go to sleep and, I wake up at night, or I don't go to sleep till 2, or, all of the kind of things that come along with it. But then you start relating the stories of the patients that have been treated for sleep apnea. And this is even outside of the bariatric surgery space. And you start telling all the patients that, the patient's grades get better, their mood gets better, their sleep gets better, their relationships get better. They start feeling better about themselves because they're actually able to sleep at night. And then their compliance starts to go up. The ultimate care that we have for these patients, right, is you have to, if you look at guidelines, a lot of this bariatric surgery, some bariatric surgery guidelines and some sleep guidelines talk about you need at least 60 to 80% compliance for wearing a CPAP machine to quote unquote be eligible for surgery. Again, that's the discussion, but that's a good carrot for people when they really want to have the surgery is compliance with that. But in terms of availability for the CPAP and use of the CPAP, it is a significant quality of life improvement for patients to be able to speak to that and to see that. And patients will ask too, okay, I have my bariatric surgery, why do I still need to wear this? Sleep apnea is one of those things that does have a 60 to 75% chance of resolution after bariatric surgery, but unlike diabetes, it takes a while to improve. And as the weight comes off, then the sleep apnea kind of gets better too, but sometimes it's actually a little bit slower in terms of outcome with that. So we really impress upon people that they need to wear their CPAP machine afterwards too, because it really helps obviously tissue oxygen delivery and wound healing and outcomes with that.
Thanks, Jason. That's fantastic and really absolutely benefit from your experience. Just a quick comment that as our program takes shape here, that it'll still be in concert with Dr. Newburn and her endocrine program as well, which actually has been in place for a long time.
Other questions? Please.
Through the weight loss, with adults, there's a lot of extra skin and plastic surgery. Is that something that you found in kids?
Yeah, that's a great question too, is the role of plastic surgery and white skin reduction in kids after their a couple years after their operation. Yeah, we see that. It's thankfully less common in kids because their skin is more elastic. And kids can be a little bit more active in the gym afterwards too, and getting up more muscle mass, and probably that's multifactorial, but we definitely have seen, I want to say probably about 10 to 15, maybe 20% of our patients after their operation have some level of skin reduction surgery afterwards. We plastic surgeons do. And it's good outcomes. And it has been universally paid by their insurance.
All right, Jason, thank you so much. This has been helpful.